there, America. Dr. Mike Sevilla here, and it's always fun when I meet people in person that I have met over the internet. And I am here in Lawrence, Kansas. I am here at NeuCare Family Medicine with the man right here. Dr. New is, I'm at his place, and I had a great tour, and we're going to chat it up. We've been chatting up for like hours, but did want to share some things with all of you. So it's great to be here, and thank you so much for the time.
Yeah, I'm glad you survived the trip.
So you've been here a couple years, 2 years, and so how? Give us an update. How do you think things are going at this point?
It's been a wild ride. Starting this 2 years ago, very few people, both in the general public and healthcare community, had ever even heard of direct primary care or a concierge medicine or whatever you want to call it. And so when I started, it was very very hard to educate people and to convince people this was a good idea, but we've seen tremendous growth over the past year, and even the past 4 or 5 months have been our best months. So we've learned a lot along the way, and my community has been very receptive, and it's gaining traction and steam. So I'm very happy and optimistic about where we're at right now.
Now, I've talked to a lot of direct medicine physicians, and they've said that, as what you're saying, is that when they started out, they had to make the case for this type of model, but now it seems like the public and the communities are wanting more to know about the nuts and bolts and how it all works. Would you say that?
Yeah, absolutely. I would say whenever I first started, and I was the first direct primary care doctor in my town, and probably within 50 or 100 miles. Most people had never heard of this concept, and unless they were like 70 years old, and then they I guess that's how they used to do things. So it was a lot of sales. People would come in and interested, and I would, in some respects, felt like a used car salesman because I was just selling them the idea, and I'm passionate about it, and I had a vision of what it should be and why it was good for them and why it was good for me. But it was a lot of work to convince our first few God bless them first few patients to kind of trust that this was something good. And it's gotten less and less work in terms of selling the idea. Of course, direct referrals help, but just people kind of, in at least my community, have started to understand what this is and why it's good.
Now, when I've talked to some of the direct care physicians before, they're using more and more digital and electronics and the EMR, and you showed me on your website, NeuCare.net, how patients can even sign up and give all of their history, and so you really feel passionate that the EMR used correctly can be used more than just as a billing thing, but used for clinical work. Can you expand upon that?
Yeah, I actually sympathize with docs about this issue a lot, and I'm a huge tech nerd, but whenever I was introduced to the concept of the EMR, which would have been 2006 or 2007, whenever I started doing a lot of clinical stuff, it was like stepping back in time 30 years, and it was very frustrating to use an EMR, and it seemed like more of a burden than a help. And I think a lot of it does come back to what you alluded to, and that it's really not a tool for doctors and certainly not for patients. And it's more of a coding and documentation tool than it is a clinical tool or communications tool. And so I really, my experience has been most EMRs are terrible, and they probably were more of an impediment to providing good care than an assistance. And I think that it's not because the technology is inherently bad. I mean, technology in every other phase of our life that I can almost think of has made our lives better and easier. It's made it easier for us to communicate with our friends and family. It's made tracking our finances easier. And the same should be true for healthcare. But I think that the incentive is not to provide better clinical care or communicate better with our patients. It's to fulfill the third-party payment system. And I think if you can remove those shackles from that technology, that it opens up all of these possibilities, which people really have never even thought about. So, there's some docs out there doing really innovative things in direct primary care and building some EMRs, and so I think we're just scratching the surface of what an EMR can be, and it's almost the part that's frustrating to me is I think that the whole concept has been muddied so much that there's doctors who just think it's inherently bad, and I don't think that's true. I think it can be an amazing tool, but I think that the incentives need to be there to use it in the right way.
Now, we talked a little bit about some of the new services that offering to the practice here. Tell us about it's kind of breaking news too. Breaking news. Exactly right. Yeah. Stay back there. Stay back there. You show me your pharmacy in the back there, and you tell us a little bit about that and some of the projects that you have to educate patients on the medications that they're on.
Well, we've from day one wanted to provide as many benefits to our members as we can, because that's how we make money. We're membership based, membership supported, and so we've added on services to make that membership more valuable as we've built. And we've wanted to do medicines from the beginning. My wife is a pharmacist, and so she has been urging me to do this probably even before I was open. But we just recently started our wholesale medication program. So basically, we buy at wholesale cost from a supplier and pass those savings right along to our patients. So we have a small markup for the price of the bottle and the label and the bag. But we're selling meds now for 50 to 90% cheaper than any pharmacy can. So it's been great. And I think there's obviously a financial advantage to patients, but I also think from a clinical standpoint, it makes it more convenient. And when you look at the issue of non-adherence, there's many factors that go into that, but cost is probably number one, and convenience, and that is a whole bag of things, is number two. And so I think when you can eliminate those hurdles, make things easier, and obviously make things more affordable, it helps patients do better. And also, we spend a lot of time, and this is speaking as a husband of a pharmacist, going back and forth with pharmacists about technical issues, paperwork issues. And what I realized is that I spend as much time doing that, and there's some great resources out there to find discount plans and those kind of things. But I spend as much time doing that as I would have actually dispensing the medicine, just because of all the administrative stuff surrounding it. So when we started the med program, I was a little bit hesitant, I think, for a while, because I thought it was going to be another thing and we wouldn't have time to do it. And we've been able to automate almost all of it in terms of the labeling and the inventory and the charges and all that stuff. So it's gotten to the point where it's almost easier for us just to walk in the back, fill the bottle real quick, slap a label on, and send the patient on their way. Better for the patient and really better for us, I think, in the long run.
And you said you've had medical students that have come here and who've read about you, but what kind of feedback do you get from students when they actually see this in person and live in front of them and actually in practice?
I think most of them, when they come here, they had chose to rotate with me because they kind of heard I did something different. But I don't think they quite understand how different it really is. And patients the same way. Medical students who had rotations prior to coming to me, which most have, even after their first few rotations, had already kind of gotten in that normal healthcare groove where it was very regimented, and they had already kind of gotten used to seeing patients pretty quickly because they were coattailing someone around. And most of them, their first comment is, wow, that was a long visit. And so we spend so much more time with each patient and can go into much better depth and answer so many more questions. And really, for a medical student, that's where they should be at now. A lot of times they have the same questions that the patient does. They have the basic science understanding that they can interpret what I'm saying better when I explain why a disease is happening or how this treatment's going to work. But a lot of times they have the same kind of clinical, practical questions a patient has. And so whenever they're rotating with me, it's nice because I can explain things to patients more. The student's usually sitting right next to me, and it's a lot more in depth with each condition.
And you even said when new patients come in, they normally go to this exam table, but then you invite them to and you say you have this desk over here, and then that's how you start off the visit.
Yeah, and I think one of the things when we build our clinic, and I have basically one big room that's my office and exam room. Whenever we build out the clinic, we really wanted to disarm people, and I don't think it requires fluffy towels and marble countertops to do that. I think it has to be comfortable, and it has to be somewhat casual, and really make people feel comfortable. And I think there's so many little things that we do in healthcare that send the wrong signal. And one of the examples of that, whenever I build up my clinic space, the room where my office actually is at now used to be kind of the reception area where it had the bulletproof window for whatever reason that we put up, like patients are going to come across and bite us in the face, or they have some contagious disease. So we took that out. I was like, it just seems very threatening, honestly. Like you're going up to some type of convenience store in the hood or something where you can't actually, talk to the people. So I said, plaster that over. We're going to set a desk out in the lobby, so when patients walk out, it's just my nurse and I. But my nurse sits out in the lobby with the people. And so when people walk in, there's not this kind of physical barrier in between the patient and their first contact. And then the same thing in my office. We usually sit down at my desk and talk. And sometimes it's small talk. I think it's important. But it really is, it makes them feel more comfortable, and it's not like, their pants are already off, setting up on the butcher block with their gown on when the doctor walks in the room. I mean, that is no way to start a conversation, in my opinion. At least not one that's very relaxed and comfortable. And
you said before that you've always been open to answering questions. And do you still get a lot of questions? And do you get physicians and health professionals that come in and see the space out here still?
Yeah. We've had several docs actually either fly in or drive in and tour the clinic and who are thinking about doing this type of model. And I'm always happy to talk to them and share my experience with them. And we've seen several docs who've come and visited us actually end up starting their own direct pay practice, and it's great. And we get emails. It seems more and more, probably 2 or 3 emails every week from doctors around the country who are, either just giving us a pat on the back or who are saying, I really want to do this, and have some questions about the nuts and bolts of it. But yeah, that has definitely picked up. I mean, in the first year, we would hear occasionally from docs, but the last 6 months, it's been a lot more frequent.
Now I know you're have all these projects in your head here, but looking forward towards 2014, are there things that you really want to see for this year as far as new services or anything else for NeuCare Family Medicine?
Well, I think the medication program, like I said, we just started that recently, so we're expanding that, and we're working on building a custom EMR with a small vendor. So I think those are kind of the 2 biggest things. As I've talked to you about, I love educating. I love health education. I want to be basically Alton Brown. Went and saw him live the other night in Kansas City. It was fantastic. So I would love to get into more doing health education, and whenever I can kind of get the business more stable and we're not working so much on that side of things, I would really like to get into that at some point. And my wife is a pharmacist, so we have a kind of a cool project that we're planning in terms of counseling people on medications.
So my last question is, can you share with my vast worldwide audience, well, what is that thing over there? If you can bring it into the shot here, and we'll
this basket.
Yes.
So I started off with a very small budget, very small, and no loans when I started my practice. So I had to think creatively about equipment. And so instead of buying a $300 infant scale, I have one a normal scale that kind of fits on the floor, and I didn't want to buy an infant scale, so I just decided to buy a basket, set it on my scale, zero it, and then put the baby in. So $12 instead of $250. So, and actually, people think it's cute. So
I think it's cute.
Money, it actually, it's very endearing. And that and my Craftsman. These are the 2 things in my office that people always talk about. It's the little things. It's the little things that make people comfortable.
It is. This is a great space out here. So
I think my kid actually broke one side of this at one point, but it still works.
Well, thank you so much for the invite. It was great to meet you in person. I know that we'll be talking about things a lot more in the future. I'm so happy that this is so successful for you. So this is Dr. Mike Sevilla reporting live here. Well, actually, this is on tape from Lawrence, Kansas.
We're recording it live, though.
It's right. This is recording live.
Yeah.
Check out the website, NeuCare.net. Thank you so much for the time.